Welcome to today's program. I am C. Virginia Fields, former Manhattan Borough President, and currently serving as the President and CEO of the National Black Leadership Commission on Health, formerly known as the National Black Leadership Commission on AIDS. In 2019, after being a leading advocacy organization and following a 2-year rebranding, the organization name was changed to that of Black Health. And we have a new mission, a new vision, and we are so pleased for the work that we are now doing as we have expanded our health focus areas. Our mission now is to champion promotion of health and prevention of diseases to reduce disparities and achieve equity within the Black community. Our vision is to reduce disparities and achieve equity to promote the health and wellness of Black communities through education, advocacy, and policy. And with a new vision, a new mission, Black Health expanded its health focus areas to include 8 health areas, including HIV/AIDS, hepatitis C, breast cancer, cardiovascular disease, mental health, diabetes, sickle cell, and mental health. And by doing this, we are now working on those 8 areas that disproportionately impact Black and African Americans. So this was a major development for the organization, an organization evolution to become a comprehensive advocacy, education, and policy group that moves beyond HIV/AIDS to address these multiple health issues and disparities, again, as I said, disproportionately impact Black African Americans. And with October being Breast Cancer Awareness Month, today I am very pleased that we are going to be discussing breast cancer, its impact among Black women, disparities, and other issues that impact our health today. And I'm very pleased to have leading our discussion Dr. Michelle Williams, who is a health behavior scientist who develops and disseminates population-specific health behavior interventions for cancer prevention and control. Dr. Williams earned both her Bachelor of Science and Master's of Public Health degrees from Florida A&M University, and she received a PhD in health education and health promotion at the University of Alabama, Birmingham. And as we were coming on, I just told her that that's my hometown. That's where I was born. That's where I grew up. And I know a lot about the University of Alabama in Birmingham. She completed her postdoctorate training in the UAB VA Health Services Outcomes and Effectiveness Research Training Program, where she also earned a Master's of Science in Public Health in Health Outcomes Research. Dr. Williams is a tenured associate professor at George Mason University's Department of Global and Community Health. And in her work, she focuses on, as I mentioned, disseminating and implementing interventions that will lead to a reduction in cancer disparities. Dr. Williams, thank you so much for joining me today for this very, very important discussion. And to get us started, I'd just like for you to share with us some of your background. How did you decide or get into this area of work? And it is so critically important. And as I move around the country and engage with a number of experts, I recognize that there are very few African American Black women too in this particular area. So, talk to us a little about your work and how you became involved.
Oh, sure. Well, thank you again for the invitation. So I initially have been in love with public health since I was a senior in college, and I didn't really get into the field of cancer until a few years after that. I met a professor at FAMU. Her name is Dr. Flokimi Odedna, and she was like, "Well, why don't you study cancer?" And I was like, "Oh, well, let me look into this." And then I took a course, an online course at that time. It was like the early stages of online classes with a professor at MD Anderson, and they were talking about cancer disparities. And I was like, okay, this is something that I can really become passionate about. So since that time, I've been focusing on cancer disparities and what we can do to help reduce those disparities in cancer.
And this started when you were in undergrad, you said? Or
Yes, my passion for public health and health education, health promotion started in undergrad. I wanted to be able to have a career where I help people prevent illness.
and that is so key, the prevention of illness, because so much happens after a person has been diagnosed. Now, one of the things that we continue to hear about Black women, especially, is that while Black women have a lower incident rate of breast cancer than white counterparts, they're 41% more likely to die from this, having lower incidence, meaning a lower number of new cases that are diagnosed over a period of time. Could you speak to that? Because that is something we hear a lot about, as well as the fact that genetically, Black women disproportionately carry what is known as two aggressive subtypes that present mostly in younger patients: triple negative breast cancer and inflammatory breast cancer. Could you just speak to those factors or issues? Because a lot in discussions, I think we all hear a lot about incidents and the aggressive, more aggressive forms of cancer.
Sure. So we can start with incidence. So it is true that Black women have a slightly lower incidence of breast cancer than white women. However, that gap is closing because what we see is that the incidence for Black women is staying about the same, whereas the incidence for breast cancer in white women is declining. So that gap in incidence is actually decreasing. But we do have a slightly lower gap in incidence, meaning the lower number of people who are being diagnosed. However, like you mentioned, Black women have a significantly higher mortality rate for breast cancer for a number of reasons. And one of those reasons is attributed to a later stage of diagnosis. So, what we know with breast cancer, as with many other types of cancer, when you diagnose the cancer at earlier stages, it's much easier to treat and people have a longer survival. But what we see oftentimes with Black women is that they tend to be diagnosed at later stages when it's more difficult to treat and survival rates are much lower. So that's one of the things that contributes to the higher mortality rate. But then there are other structural and systematic barriers that also contribute to that significantly higher mortality rate among Black women. And those things include Black women living in communities that don't have cancer centers that can treat them. So that's a systemic structural barrier where women would have to travel a significant distance to actually get treatment. I mean, let's think back to Alabama, for example. If a woman is diagnosed in a rural area in Alabama, she would have to travel a significant amount of time to get to the Comprehensive Cancer Center in Birmingham. And that can oftentimes be a significant barrier because of cost and other things like that. So those are some of the factors that contribute to those significant disparities. And then, like you mentioned, when we look at the different types of breast cancer, because breast cancer is an umbrella term for several different types of breast cancer, there are different types of breast cancer that we see more prevalent among Black women, and that includes the more aggressive types. But then also, we start to see those aggressive types, especially triple negative, more commonly in younger Black women. And I know the term young is subjective. So when we say younger Black women, we're referring to women under the age of 40. And I've known myself several women under the age of 40 who were diagnosed with breast cancer. And part of the problem is that oftentimes when they present at hospitals, they're presenting with later stage forms of breast cancer that's more difficult to treat. But we also seem to see those more aggressive forms of breast cancer in younger Black women.
Yeah, but with so much more awareness and outreach to have, get mammograms and talking about breast cancer, especially during the month of October. But fortunately, in your work, it's 365 a year. And in our work now, as we have expanded our health focused areas to include breast cancer, we do much more work than just the month of October. So, with this, are we seeing a change? I know you said that, there's been some slight reduction or increases, but what is it from your experience that we must do in order to escalate these changes that are needed, including transportation, access to health care? And I don't think Alabama, uh, as of yet, approved affordable health care. I don't think that they made that decision. Is that correct?
That's correct, from my knowledge, yes. Right.
Okay, so, and I'm sure that that plays a role in all of this. So, from your work, what do you suggest or think we need to do more of? Because this is very, very, frustrating to see in 2023 the numbers that we're still seeing, and now younger women. So, what are some of your suggestions of perhaps what organizations like my community based organizations and others who will be watching this show should be thinking about doing differently? That is.
Well, honestly, we have to do everything differently, right? So you mentioned awareness. That's an important part. That's my job. That's what I do. I develop these culturally relevant cancer education interventions aimed at increasing awareness about breast cancer and the importance of screening and early detection. But that's just one part of it. You can have somebody who is extremely aware of cancer and has all the motivation in the world to go and get their mammograms on a regular basis. But if they don't have easy access to those services, then there's no screening happening. So when I say we have to do everything, that means we have to continue at the individual level where we're looking at increasing knowledge and awareness and increasing that motivation to get your screenings and follow up on abnormal findings. But we also have to make screening affordable and accessible. So going back to my example of women living in communities that don't have mammograms, that's a real thing that happens, right? I think some of us who live in larger cities who can go to multiple hospitals and get a mammogram done, we take that for granted because there are women in communities that don't have that easy access. So we have to make sure that women have that access to screening and then have the ability to actually afford care, because that's also another part of it. Cancer can be very, what we call, financially toxic. And when we see that, a lot of women cannot afford care, that's a problem, because if they're not affording care, then it means they're not getting the care that they need to help sustain their lives. So we have to make care more affordable as well. So we have to do all these things on these different levels, the individual level, making people aware. We have to do things on the organizational level, making sure that we have access, but also at the policy level, making screening and treatment affordable.
That's a heavy load, and it has to continue. And I'm glad that you went through all of the different steps that must be taken, because sometimes we get we stop after one level, say just make women aware without thinking about what else is needed, having access, being able to afford it, and having the resources in one's community so that they don't have to travel so far. Because what I think we recognize with all of these disease areas that which my organization is focused, is that if there is not the information, if it's the education is not there, And if there is no access to transportation, we are continuing to see fall short of the goals that we would certainly even like to see. So, can you talk a little about the participation of Black women in clinical trials? That is also very critical in reducing health disparities.
Yes, absolutely. Clinical trials are very important in regards to developing treatments that can help. But one of the things that we see is that there is definitely underrepresentation in clinical trials of Black women and Black people in general. Um, there needs to be a much better job of not only funding clinical trials to be able to recruit more Black women, but also reaching out and educating Black women about what clinical trials are and the importance of actually enrolling in them, and then making them themselves more accessible. I can give you an example of my mother. A few years ago, she was in the hospital, had a cardiac issue, and we were at an academic medical center. She was in the recovery room, and at least three people came in and talked to her about three different clinical trials. Now, I don't think that was the best time to talk to her because, as the patient, she's already overwhelmed. The information just wasn't presented in a way that she herself, 70 plus year old woman, don't get mad at me, mom, a 70 plus year old woman could understand. And then, when we did convince her, hey, this is a good idea, you should try and enroll. One of the trials that she actually did go to, she had to drive a significant distance to get to the enrollment center, and then when she got there, she wasn't eligible. So we had to consider all those different factors and make those factors more accessible to Black women. Is it necessary to have them all drive all the way into an academic medical center? Is there some way that we can enroll people virtually and do things virtually, right? So we need to do research into how can we do a better job of making these clinical trials accessible to Black women.
And is that happening in terms of looking at ways to make clinical trials more accessible? Is that an area in which you are working or focused on?
I am actually doing my part in this. Yes. So I recently had funding to do a study where I was looking at doing just that, doing these baseline assessments like taking weight and blood pressure virtually. So with the project that I did, I enrolled Black breast cancer survivors in Mississippi and Alabama. And what I did was I mailed them a kit. Like the kit included a weight scale, a blood pressure cuff, a waist measurement. And so we did all of those types of baseline measurements that they oftentimes do at these academic medical centers. We did that in their own home. And so the purpose of that study was to initially just show the feasibility of doing that type of enrollment in someone's home and making it much more accessible. But we need much more research on this to show that, we can do things in a different way to get the target population that we need.
How do you assess the response from that trial that you engaged, the women, I think you said Alabama and Mississippi?
Yeah, so
About how many women were involved and what was the outcome?
Yeah, so again, the purpose of that project was a feasibility. Is it feasible to do this? And so I enrolled about 35 women, and the outcome was very positive. We had very positive results. I was online, I did the assessments with the women, went through using the scale and the blood pressure cuff, and it all just showed that it is feasible to take these types of baseline measurements and then subsequent follow-up measurements in the comfort of their own home without them having to travel that far distance. So it is feasible to do that.
Now that sounds very encouraging because we have tried, in our work from time to time to engage Black African Americans in clinical trials, and it's an uphill battle. It has to do with mistrust. It has to do with a lot of issues in the medical field that people still remember and don't want to see all of the changes and the improvements that have been made. And one of the things that we also find is that when there is a Black researcher or a
Mhm.
Black person leading the team, we have also seen more positive results. And I think that goes to something we all hear a lot, that when we see someone in these high level positions that look like us in terms of race, gender, it makes a difference in terms of the response
Mhm.
for participation. So clinical trials, I fully support them. I've been engaged in one probably many years ago, and it's very time consuming. And I have a niece who lives in Virginia, actually, but she was participating in one at the University of Alabama in Birmingham. And I remember the number of times she had to travel there. So to hear you say that they could look at doing it virtually in other ways, new ways for addressing this, I think is very encouraging.
Mhm.
So talk a little bit more about other things that you're doing in your work as a health behavior scientist.
Yes, so I'm doing a lot of amazing things right now. Actually, one of the projects that I'm working on, I'm working in conjunction with the Mississippi State Department of Health, their comprehensive cancer program. They have funding from the CDC. And so, what we're doing is we're trying to train community health workers to be able to provide information to lung cancer survivors about how to live a healthier life. Because what we know is that with lung cancer, it's the leading cause of cancer death for both men and women in the US. So, we want to focus on how can we help people who have lung cancer or have had lung cancer have a healthier life. So we're working on that program right now where we're aiming to train about 100 community health workers. And I also have funding from another the Prevent Cancer Foundation to work on a similar project where we're focusing on training community health workers to educate people about lung cancer screening in Mississippi. And the reason that we're focusing on Mississippi is because it has a very, very high rate of lung cancer disparities. And so we want to see that go down. So those are some of the projects that I'm working on right now that's focused on cancer disparities.
And you mentioned lung cancer as being one of the leading causes of death, and that's partly why you are working, looking at that. How does that relate in the differences between women and men in terms of lung cancer? Do we see higher rates, differences in terms of gender?
So, yes, so men overall tend to have higher incidence of lung cancer, but lung cancer is one of those that people often don't get diagnosed until it's very late. So that's why we see like both men and women, that's the highest mortality. Lung cancer is the highest mortality for cancer, both among both men and women. But men tend to have more risk factors for lung cancer, including things like smoking. So we know overall that men tend to smoke more than women, and then also occupational exposures. But that doesn't like eliminate women, but men tend to have higher rate, higher incidence.
And what about the age factor, especially with younger people? Well, one of the things that we're seeing and hearing is that younger people are not smoking as much as we used to see. Is that accurate? Or I see your face.
Well, they may not be smoking cigarettes as much, but young people are still smoking other things that can contribute to lung cancer that they don't think so. So, for example, I had this conversation with one of my doctoral students the other day about hookah, right? So we know that hookah is very popular among younger individuals, and they don't consider that to be smoking, but hookah is still tobacco, so that still contributes to some increased risk of lung diseases. So that's why screening is very, very important. Lung cancer screening is very important.
Interesting that you would mention hookah because so many places are opening up now where you go in and once was required that there should be a screen to separate persons who are on the other side. But I'm seeing that is not happening because I've been in restaurants where it's just open and I make a choice to stay or not to stay. But I don't know what other people, decisions might be. But shouldn't there be that kind of a separation, especially because of the impact of the smoke?
I think as we start to do more research on hookah and vaping and all of those things, we'll probably start seeing those things added to the list of things like the cigarette bans, right? Because I remember when I was young, you could go into a restaurant and everybody would be smoking too. But we've seen that be phased out. So I think over time, with the more research that we have that can show more conclusive evidence that hookah and these other types of smoking are also contributing to lung diseases that we'll probably start seeing those things added to the list of cigarette bans and things of that nature.
So clearly, Dr. Williams, you are a wealth of information and you have just touched upon a number of the issues that impact our health severely and critically. And I'm just so appreciative to hear about all of the work that you're doing. So, in the last minute that we have, is there anything you would like to share with our viewing audience about breast cancer or prevention or other information that you think would be of value?
Oh, absolutely. With breast cancer, I just want to reiterate the importance of mammograms and screening. I know that in 2023, a lot of people think, well, all women, they get mammograms when they start to be 40, but that's just not the case. We still have a lot of women who are afraid to get mammograms, and we have to overcome that fear and understand that in order to live our best life, we have to have health, and that prevention, that secondary prevention with the mammograms is very important. But also just living our best lives, getting exercise, reducing stress, eating a healthy diet, not smoking, all those things can contribute to the reduction of the risk of breast cancer. So we have to do that. And then also, I just want to encourage women to talk to each other. Mothers, talk to your daughters. Sisters, talk to your other sisters. Nieces, talk to your aunts about these things. Because I remember when I was young, my mother talked to me about getting her mammogram. So we have to start sharing this information within our own families and our communities.
And thank you so very much. And would you just like to give us your contact information if someone would like to follow up with you, your email or your website?
Absolutely. You can reach me at mwill29@gmu.edu, or you can visit my website, drwilliamslab.org.
Thank you. Thank you so much, Dr. Williams. You are a wealth of important information. And I want to thank our host, the Manhattan Neighborhood Network, who brings these programs to you to better inform you, our viewers, about the important topics that impact your health and well-being. So please let your family, friends, and neighbors know about this programming. And again, I am C. Virginia Fields, and I thank you for joining us and hope you'll tune in next time for Health Action.